So let me just start by saying good morning, good afternoon, good evening to all of you who are joining us here today for this presentation on these emerging tools for postpartum hemorrhage. I'm going to start by passing it off to Jeffrey Smith to give us a very brief introduction. Welcome.
Great, thank you very much, Dilys. My name is Jeffrey Smith. I'm the Deputy Director of Maternal, Newborn, and Child Health at the Bill and Melinda Gates Foundation. And let me first start by thanking Dilys, Elizabeth, Nicole, and their whole team for all the work that has gone into understanding the scenario of postpartum hemorrhage and looking deeply at the emerging tools. This is going to be a fascinating and really important webinar for all of us. I'm really pleased to see that about 50 people have joined. I'm sure others will join, and many of you will echo this information to your colleagues because PPH is a critical issue. It remains the #1 cause of maternal mortality, as we all know, and it is central to any effort to both reduce maternal mortality and improve maternal health. A recent analysis looked at postpartum hemorrhage mortality and identified three domains or three aspects that were really critical: cesarean section, maternal anemia, and quality of care. And so I think as we look at continuing to evolve and improve the global approach to maternal mortality reduction, we have to think about new solutions and solutions that allow us to address the complexity that postpartum hemorrhage presents as both a cause of mortality, but also as an issue that vexes and challenges providers. There is an incredible amount of good work going on in the world regarding postpartum hemorrhage, and we continue to learn. I know that there is a plan for a Lancet series on postpartum hemorrhage to be authored this year and released next year, and I think that will continue to gather, summarize, and release new information. But today's webinar is really an opportunity for us to look at a slice of this that is really critical. We need to continue to evolve our solutions, and we need to think about solutions that are easier to apply, that are safer, that are more effective and quicker. And so I think that the information that we will learn today should really simulate a robust conversation in our community to determine how we address this issue and continue to support providers on the front line who are addressing this challenge. So I really look forward to what we will learn, the emerging conversation both today and beyond this webinar, and the new solutions that will come as a result of this. Again, I thank Dilys and her team for their incredible hard work and their vision in addressing this issue. So I'll turn it over to you, Dilys, with both a note of thanks and a note of excitement for what's to come. Thank you.
Great, thanks so much, Jeff. And let me just start by letting everybody know we are recording this presentation and we will make it available on our website for yourselves or anyone else who might want to watch it. I'm going to begin also with returning that thanks to Jeff and to Amanda Cafaro, who both at the foundation have helped us through this process. Just to give you a brief overview of how we're going to spend the next hour, myself and our team are going to give you the results of the activities that we've been conducting for the past few months. We're going to hear from a Kenyan obstetrician and midwife who have a long history working together. And then we're going to hear from WHO and open it up for a Q&A. We have a lot to cover, so we're going to dive right in. Please do use the Q&A function in the webinar down below if you have any questions or comments, and we will be manning that during this session. Thanks. Next. So why can't we stop the bleeding? Jeff already mentioned the importance of the problem of postpartum hemorrhage and its contribution to maternal mortality. And despite all of our best efforts and everything we already have, sometimes everything we do just doesn't work. Many of you are very aware of the uterine balloon tamponade, which is the most recent addition we have to our sort of tool armamentarium. And I think, as many of you know, it comes with some drawbacks, some complications. It's not super easy to use, and some conflicting data, particularly when you talk about context and setting in which it's used. And finally, I think I want to just reiterate that there are lots of management options that we have and we use, but they are not used optimally and are not scaled effectively. And by that, I mean things like TXA, non-pneumatic anti-shock garment. So new tools and devices are not the only answer to this problem. Next, please. So what are we actually here for? There are a number of new suction and sponge devices for postpartum hemorrhage on the horizon. They're coming quickly. This project aims to identify the most urgent research questions for these emerging tools and devices, and specifically for their use in LMICs, where we know the majority of the burden is. Our hope really is to strengthen and actually catalyze collaborative research efforts that can inform and accelerate the all-important WHO guidelines. Next, please. Our work has been unfolding in 3 phases. The first phase was a literature review of any of the existing data, looking for new tools and what we know about them. We followed that with a series of key informant interviews. Many of you on the line may have been our subjects for that, to get some early perceptions and ideas on these research priorities. That also informed 2 different surveys. Again, you may have completed them, a product profile survey and a research prioritization survey. We're here now to share the results of those first two phases, and this will be followed by a more in-depth discussion, expert convening to discuss these findings and try to reach some consensus to give guidance to researchers across the world to work on this. This is a very short presentation. We've had to distill it to the sort of most important points, but it is all available on our website. You can see the link here, as will be the recording, and including all of the data that we did collect. Next, please. Next. So let's start with the literature review and the key informant interviews. Next. So we looked into 6 tools, and you can see them illustrated here. 4 of them are suction tools, and 2 of them are sponge devices. The first 4 suction tubes work by being placed inside the uterine cavity and attached to suction, whether it's electric suction or pump or manual. The first device, the JADA device, is an FDA-approved device by Organon, placed in the uterus connected to suction. Similarly, the Levine gastric tube, which is an existing gastric tube for gastric use, is now being used for intrauterine usage. Similarly, there is a team working on a modified approach using the Bakri balloon that we know for UBT, in which they place it into the uterine cavity, use the balloon more for a cervical seal, and use the drainage tube to create suction, or to introduce suction. And then the suction cannula, and this last one is the only one whose developers we were unable to contact and speak with directly, but this is basically using a regular intrauterine cannula attached to suction. The 2 sponge devices, there's the XStat sponge device, which was developed specifically for postpartum hemorrhage. It's basically a mesh bag filled with highly compressed sponges that, when they absorb the blood from inside the uterus and deployed, they expand and create a tamponade. And then finally, there's the Celox gauze, which has also been around for quite some time, which is gauze that has been covered with chitosan, which is a product made by shellfish that leads to coagulation that is not dependent on the coagulation cascade. So these are the devices that we looked into. This is a busy slide, again, it's on the website, but they have very different characteristics, some that we know about, some that we don't yet know about. Only 2 of them were purpose-built, in other words, built specifically for uterine hemorrhage, the JADA device and the XStat Sponge. They were all designed to be effective for uterine atony. They have variable degrees of how long they need to be left indwelling, whether or not a specialist is required, and some other factors. Next, please. Let me review very briefly what is the state of the published evidence and literature. You can see across the first row the total numbers of studies that have been published on each of these devices. The largest study is indicated in the next row there, or for each of them. And I'll tell you a little about each of those studies, but there's only one randomized control trial that has preliminary data. You can see that all of them are with a very limited number of participants. They have not all been tested in an LMIC setting, and they are all used in a hospital context, inserted by OBGYNs, and with very variable outcomes. So it makes them very difficult to compare, and their use is quite varied. Next, please. I'm going to turn now to what we learned from our interviews. We interviewed 19 stakeholders. 14 of them were either from LMICs or had extensive experience in LMICs. They represent a diverse array of stakeholders that you can see illustrated here. And we had 2 different surveys, one which was for the actual developers or primary champions of a particular device, and the other that was for everybody else. Next, please. One of the findings that came out of the interviews that we thought was notable was this opinion that was split on whether we should be moving forward with purpose-built or bespoke devices versus improvised tools. As you can see, some of them are designed for other purposes and being repurposed. And one of the funders, these are 2 quotes from funders, if we can do something that doesn't require a separate justification specifically for maternal health, this might be an appealing option and easier to keep in stock. Whereas another funder said, the tinkering approach is not acceptable for this class of device. Next, please. We spoke with our interviewees about these tools and their use across the research continuum. So from efficacy, highly controlled studies, to use in normal circumstances, to implementation and scale. Everybody, there was real consensus that most agreed that efficacy for any of these tools has not really been demonstrated. We don't have enough evidence in efficacy trials. However, most really emphasize the importance to keep in mind effectiveness and scale up as one is making decisions about those specific efficacy trials. And to go into that just a little bit more, next, please. What do we mean when we talk about, these effectiveness considerations, or what are the contextual elements that are so important? And I'm going to start this with a brief quote from one of the clinicians we interviewed. The UBT, or balloon tamponade, in my hands is seen as effective. But if you take a device to places where PPH occurs at practice level, lower cadre people with less than optimal skills, or even Health Center 4, where the majority of deliveries are occurring, you may have different experiences. And some of those contextual factors you can see are listed below, but they're diverse. There's many of them, they're varied, and they're all important to really understand before launching any type of study. Next, please. So let me summarize our phase 1 findings. There's no question these new tools are on the horizon. There's varied evidence for them, although none of it is really sufficient to prove efficacy. There is a need for a target product profile that aligns with context and setting. And it's really important at this stage in the development and use of these tools that we as a community of stakeholders come together around some sort of coordination on efforts for the research. And this is with regard to design. There are so many different designs that people are talking about, setting, and specifically, we need to start thinking about what are the important standardized outcomes. I'm going to move now to a discussion of phase 2. We have Elizabeth Buttrick, who is a senior program manager here at UCSF, who's been working for many years on postpartum hemorrhage, and she's going to share the results of the product profile survey that we conducted. Elizabeth?
Thank you so much, Dilys. As Dilys mentioned earlier, in phase 2, we developed 2 different surveys, one designed more to get at the user perspective and what would you want if you were going to decide to implement one of these tools in your setting, and another that looked more at what are the important research considerations and questions. Both of those tools were piloted and then snowball disseminated to over 500 individuals in the field who are maternal child health practitioners, people with an interest in PPH, using the literature and our professional networks. And I'll talk about that product profile survey specifically, and then I'll hand over to my colleague Nicole to go over the second one. This one was designed again to identify those important characteristics in a given tool. And it wasn't specific to any particular tool, but rather what are the characteristics you would want in any tool that you would potentially want to use in that setting. We compiled the data from the opinions of all of our respondees to inform sort of a draft target product profile. And we'll look at that together in a moment. And we hope that this information will be able to help us inform which tools should be prioritized for research. Of our 500 plus people we sent our survey to, we got a final sample of 89 people who completed it. A little over half of those were from LMICs, and about 3/5 of those were actually providers in LMICs. So we asked our respondents a series of questions about kind of a group of characteristics. This is a group of characteristics on the screen you see that's all about the setting in which it should be used. And looking at other TPPs we found in the literature, we saw other folks had used 75% as a threshold for consensus. So we went ahead and used that and looked to see which characteristics rose to the level of at least 75% of all respondents saying that that was an essential characteristic. And you can see here in this example, that includes use in tertiary hospitals and use in district hospitals. We then, because they could only choose one answer, we then took the combination of essential plus desirable, which was the next category, and combined those for desirable to see what proportion passed that 75% threshold for desirable. And you can see in this category of setting, all of the other responses passed the desirable threshold, if not the essential threshold. So putting those all together from the 15 or so characteristics we asked about, we saw a few things only rise to the level of essential across all of our respondents. The ability to use a tool for uterine anatomy following either vaginal or cesarean birth was seen as essential, and use by OBGYNs in tertiary hospitals and district hospitals was seen as essential. There were also lots of characteristics that rose to the level of desirable, and as Dilys mentioned, this full list is going to be available on our website so that people can look at it more closely and with more time later. But I think the desirable characteristics do give some important indications towards what's important to people. And the essential ones are clearly base characteristics that anything in this category needs to have. We also asked our respondents to rank all of these categories of characteristics to get a sense of what was most important to them. Within the individual categories, we saw what was important, but also what was important overall. And we looked at that broken down both by all respondents and among our LMIC respondents only. Those top 5 important categories are the same across these two groups. There's a little bit of a difference in order, but they are sort of what you'd expect: efficacy versus risk, clinical indication for use, product cost, and timing of use during the algorithm. After that, there's some variability in the rankings, with reusability being a little more important to our respondents from LMICs. We also looked a little more closely at the respondents just from that subset of respondents who were from LMICs, because this is the perspective, this is where we ultimately want to be able to deploy these tools. It's where the burden is greatest. So we wanted to make sure we were seeing those views. When we looked at just that group, there were 5 additional characteristics that rose to the level of essential in terms of passing that bar of 75% in just the LMIC respondents, and that was use in private clinics or hospitals, can be used when the bleeding continues after the initial response, not just when all things have been exhausted, in-person training with either simulation or models, and then the ability to have a tool inserted by a midwife, medical officer, or clinical officer, so not just an OBGYN. Since there were relatively few characteristics that met the essential threshold, we also did a further examination to see what would happen if we lowered that bar a little bit, to see sort of what did we still get most people in our LMIC respondent category who thought a characteristic was important. And several other things came up there: cost, more about training, the ability to store a tool at ambient temperature, the ability to insert it by a single provider and quickly, and of course, something that works as well as standard of care with no increased risk to patients. We then took those characteristics, any of those that had reached at least the 65% threshold for LMIC respondents or the 75% threshold for all, and we mapped them against some of the tools. And this is more of an illustrative mapping. It's based on our impressions from interviews and our reading of the literature. It's not a definitive mapping, but we wanted to get a sense of where do these tools stand now compared to these characteristics that are important to our respondents. What you can see is there's a few, like some of those essential ones, like the ability to use it for uterine atony, that clearly are met by all of the tools out there. But there are also a lot of questions. There are some characteristics that there might be some challenges around, like cost, and there are many that we still don't really know or have any evidence, like about which cadre can use it or which setting it can be used in. There's quite a long list of these, so again, you may want to look at this more closely on our website, but I think the takeaway message here is that there are still a lot of questions about these tools, and a lot of them are about some of those end user characteristics that are important to members of the community. So in summary, around the product profile survey, we did see a lot of interest in these tools, especially for uterine atony, if we could prevent further blood loss or prevent surgery. But we do want to see tools that have no added risk. So it's important for us to understand that. We want to see tools that are inexpensive and that can be stored at room temperature. And there is some recognition there that there could be different settings or different needs that these different tools are meeting. A couple of additional characteristics emphasized in particular by our LMIC colleagues was a desire for a broader range of settings, a broader range of cadres that can use the tool, and earlier usage in the PPH algorithm. Reusability is more valued by our LMIC providers, and there's clearly a need and an importance for in-person training for colleagues from LMICs. So with that, I'm going to turn it over to Nicole Santos, a fellow research program manager here at UCSF, who will take us through the research prioritization survey results.
Thank you, Elizabeth, and hello, everyone. As Elizabeth mentioned earlier, the research prioritization survey was designed to elicit input on critical areas related to efficacy, effectiveness, and implementation science research. While some questions, like those related to knowledge, perceptions, and general research areas, were not specific to individual tools, we did give participants an opportunity to select priority tools they would want to see evaluated in a theoretical efficacy study. Next. As you can see here, we had a total of 66 respondents, the majority of whom identified as a healthcare provider. Many of these were OBGYNs who worked at tertiary, academic, or private facilities, and over half were from LMICs, with another 23% having experience in these contexts. Next. Overall, most of our respondents believed these tools had a lot of potential and saw a lot of value in pursuing them, rating them as somewhat important or very important. They mentioned the top 3 challenges these tools could help overcome, and these included 1, the inability to manage PPH alone or with limited personnel; 2, the inability to stabilize a patient prior to referral to a higher level facility of care; and 3, difficulty with other available tools such as UBT. And we'd like to note that a higher proportion of LMIC respondents chose the top 2 challenges. Next. When we asked respondents, when introducing a tool like this, what type of research was a top priority? And despite the lack of efficacy data in the published literature, effectiveness research rose to the top. This was then followed by efficacy and safety, feasibility and acceptability from the provider and patient lens, as well as implementation science research. Next. When we dove into the perspectives from the provider, women's, and health system, we had 3 top topics listed here that respondents identified as key priorities. These included feasibility and ease of use from the provider perspective, the level of pain a woman might experience with placement and removal, and cost effectiveness. Next, our respondents with LMIC experience ranked length of time of insertion, as well as supply chain / device maintenance as higher priorities, indicating that these might be key contextual factors that need to be taken into account for any future research studies. We then asked respondents to select a tool that they would like to see used in a theoretical efficacy study. And you can see from this slide that various combinations were chosen. With regards to the intervention, intervention arm, leading interventions were the purpose-built tools, the XStat sponge specifically, as well as the JADA device. There was no clear consensus with regards to the comparator, with over half choosing standard of care. Among our LMIC residents, those that lived in LMICs, again, XStat and JADA, the purpose-built devices, rose to the top with an increased interest within the gastric tube. We want to note this is probably skewed by prior knowledge or experience of these tools. When we asked respondents where they would like to see this research conducted, you can see here that there was a desire to evaluate these tools across a variety of facility types. On the left, you can see all respondents, and on the right, those that are from LMICs. The latter chose primary health centers and not-for-profit missionary hospitals to a higher degree than all respondents. And this really aligns with the product profile results that showed that we wanted these tools to be essential at the tertiary and district hospital level, but desirable at the primary health center level. When we asked respondents who should be trained to use these tools, you can see the overwhelming response was the OBGYNs and the midwives. And again, this aligns with LMIC responses from the product profile survey. But you can also see that among LMIC residents, there was an increased selection of lower cadre providers to be able to use these tools, such as nurses. We then asked respondents when during the PPH management algorithm would you use these tools? And you can see a diversity of opinions here, most of whom selected using these tools after second-line urotonics for treatment failed. But interestingly, when we looked at it between LMIC experience and non-LMIC experience, you can see a higher proportion of respondents would have wanted to use these tools earlier. And again, that aligns with the product profile results showing that they would want to use these tools potentially after the initial response and bleeding continues. There was no clear consensus for a primary outcome measure. As you can see here, the composite measure of several outcomes was selected as a leading choice. And this really comprised measures related to blood loss, maternal morbidity and mortality, as well as additional interventions that needed to be used. So the key takeaways from the research priority key findings is that there's generally interest in pursuing all of these emerging tools, but there might be a potential preference for bespoke, purpose-built tools. LMIC respondents did not limit research to tertiary or academic facilities or use by OBGYNs, again, underscoring this idea of what can we learn from efficacy studies that have implementation, that have effectiveness elements to it. Overall, we see that different tools might meet different needs depending on the context and settings, but I think what this survey really highlights is that there's real opportunity to align some of those research elements across any future studies. And that might be, for example, timing of use during the algorithm or primary and secondary measures. So with that, I'd like to turn it back over to Dilys.
Great. Thanks very much, Nicole and Elizabeth. I just want to reiterate that we do have this presentation in a sort of webinar function. So we can't we're not going to be able to have people speak, but we would love you to either introduce yourself and or write Q&A, write any of your questions in the Q&A. I know we're presenting a lot of information and a lot of detail, and a lot of it is quite nuanced and is going to warrant some deeper discussion. I'm going to sort of summarize a couple of the thoughts that we had about what do we do with all of this information, and then we're going to move on and to get some important insights from actual end users. But we were struck by how in many cases, the views of LMIC respondents diverged from those of high-income country respondents. And that is specifically around this issue of one of the areas is the fact that in the LMICs, midwives really need to be included in the use case. Though we lack the efficacy data, it's really important that you saw how everybody wants effectiveness research, that we need to do that efficacy research, but we need to think about it in the context of effectiveness research and what can we already learn about some of those effectiveness contextual factors as we're doing the efficacy research. And finally, given the wide array of tools and contexts and outcomes, it's really important that we try to find an opportunity to coordinate research efforts around this such that these learnings can be shared effectively and equitably across those stakeholder groups that find this work so important. Next, please. I want to reiterate that all of these results can be found on our website. You'll find it in much greater detail with lots and lots of tables and figures. Also, please do contact us if you have any questions or have any interest in collaborating. Next, please. We're going to move to provider and WHO reflections. One thing I did want to call everyone's attention to that I didn't mention when I was sharing the research landscape, and that is that we did find 2 studies in clinical trials that are ongoing. One in Vietnam that is involving the Levine gastric tube, and another that will be starting in Ghana, which is a trial of the JADA device. So with that, I'm going to ask that Mariana, Alice, and Anthony turn on their cameras. Great. We're going to start. Alice, you're there. Great. It is my real honor. We're going to start with a brief Q&A with a obstetrician midwife pair that I think is one of these models that reflects the kind of mutually supportive and mutually respectful relationship between an obstetrician and a midwife that is so essential for effective care. So with us, we have Alice Karuri. She's a practicing midwife and trainer. She works in a high-level district hospital in Kiambu County, Kenya. She has over 30 years of experience and has worked at many different levels of hospital care across the country. We also have Professor Anthony Wanyoro. He holds a master's degree in obstetrics and gynecology and a PhD in epidemiology. He's an associate professor in OBGYN at the School of Medicine at Kenyatta University with over 25 years of experience both delivering care and conducting research. So let me start with Alice. So Alice, considering context, which you understand also well, how do you think it is, how important do you think it is that a device be available to a midwife as well as a doctor? And are any of these tools better suited to use by a midwife in a setting such that you find yourself in?
Thank you. I would say, yes, the best tool would be one that can be used both by the obstetrician and the midwife, simply because in our setup, most of the deliveries are going to be conducted by the midwives, especially in lower levels, despite in the higher levels, like where I work, where you are going to get a doctor who is going to assist you. And any one of us who has managed PPH actively, you will know that it is not very easy. When you are confronted by a case of PPH, when you are very joyous, a baby has come and the mother is well, and all of a sudden things go haywire. There is a lot of anxiety and panic. At this time, you even tend to forget, the midwife even tends to forget the things they know very well. And this is simply because we are fighting between two forces, either to have the mother alive or to lose her. And so if we can get a device that can be used across all the levels of care, it would be very great.
Thank you, Alice. And I think that those real world experience are so critical to ground us. Anthony, in your opinion, do you think there will be or should be different devices or tools for different levels of facility? Or do you think it's more important that there's a universal approach across any given health system?
Thank you, Dilys, and I'm happy to be here. So, having worked for several years in lower middle income country, we know the existing constraints that we have. And when we look at new systems to take care of things like PPH, I think we demand a system that is quite robust and with several attributes. So the device should be easy to train health workers on. It should also be easy to scale it up to the rest of the country. It should be easy to use. And of course, we also think of issues to do with the power or how to power the device. Is it a device that will need continuous electricity, etc.? And of course, the patient acceptability of the device. We also think of devices that probably, because of the various constraints, the financial constraints that we have, a device that would be reusable. So when I look at either device, I think a universal singular approach device may be able to fulfill many of these criteria. However, either of the device may have its pros and cons. When I look at a universal singular tool device, I find a bit of attractiveness in it, in that using such a device may be cost effective in countries which are constrained by resources, like the lower middle income devices, because basically we will be able to invest in one device that can be deployed across the health care system. This may be easy to source, and it may be easy to maintain, and we may have a universal training package which can be used to train both the higher cadre healthcare workers as well as the lower cadre healthcare workers. And this will create also teamwork, which we know PPH management involves a lot of teamwork. When you look at the distribution, the production cost, infrastructure development for use of such a device, and as well as maintenance, which is a major problem, you'll find that you'll be able to train a pool of people to be able to maintain a universal singular device than when you have a facility-based device. However, on the other hand, of course, a facility-based device may have its own advantages because we can develop devices depending on where they will be deployed, such that we develop high technology devices for referral facilities, looking at the expertise that is available there, as well as the complexity of the cases that are handled at the referral centers. But we also develop cheaper devices which are effective for the lower cadre, for the lower level facilities. However, when we look at facility-based system, I see difficulties in, of course, maintenance of the supply chain, as well as sustainability and logistical difficulties that may be there in setups which are lower and middle income facilities like what we have in our country. Thank you.
Great. Thank you, Anthony. You have certainly laid out the lay of the land in terms of what we all need to be thinking about and considering. I'm going to go back to you, Alice. As a midwife working every day in this, do you have any particular concerns about introducing any of these devices in a setting like yours? Anything that worries you?
I wouldn't say it is a problem to introduce a device, especially for somebody who has ever managed or come across a PPH case. It's only that it would depend on which device. Again, I would reiterate and say, for midwives, like when we come to the suction devices, quite a number of our midwives are going to shy away because you find that like now we are trained on MVA for post-abortal care. But when we get a case of MVA, you will see quite a number of nurses and they are trained, the midwives. They are going to shy away and leave it for the clinician, contrary to a device which is just going to involve packing, or because you even get them improvising the normal things that we have to, like gauze and cotton wool, to pack and see whether we can control the breeding as we look for other care. Otherwise, for introduction of a device, there would be no problem. Only that we have to do a pilot study and training to see the effectiveness, and people have to have the skills. And again, in that, we have to follow the protocols so that it is allowed by the regulatory bodies and the ethical issues to be looked at, so that the device is seen and it is not going to do any harm to the mothers, or it is not going to contravene of what they feel it should be the best care given to them. Thank you.
Great. Thank you, Alice. And I think those this point of do no harm also rang true throughout the whole work that we've been doing. Anthony, last question for you, and then we're going to move on to Mariana. I know that you're both involved in training of new young providers, and you've lived through the introduction of TXA, UBT, and other things. And I'd like to know whether you have any advice about training or strategies for the introduction of these devices that might be overlooked. Anthony?
Yeah, that's very interesting, Dilys. But having been involved in quite a number of new introductions in the health, in the maternal child health portfolio, I've seen a lot of training related to new therapies and new devices often focuses on that solution itself, not forgetting that we need to look at the whole system to understand existing drawbacks and why the current therapies have not worked optimally. So any training should basically aim at strengthening the system that is already existing and looking at what is working and strengthening that is working, as well as looking at what is not working and trying to understand where the weaknesses are, so that we can be able to reduce systemic weaknesses that lead to failure of systems. So when I look at introduction of this such type of system, I would look at maybe the training on understanding on what works with the current PPH protocol and what is the inherent drawbacks and weaknesses that we have in the current PPH protocol that may contribute to what we are having, which is the geographical disproportion burden of PPH. Then the training should also emphasize on how to modify the algorithm that is existing for specific situations. For example, I wonder why in low and mid-low income countries, whether we need to wait until the PPH becomes refractory before using the devices, or can the devices be used earlier? Then we also need to ensure that teamwork and debriefing is inculcated in the training, as well as ensuring that emergency, strengthening of the emergency responses to other obstetric emergencies is not left behind, because we are looking at the whole system when we are doing the training. One of the other areas that we always forget when we are doing training is the issue of data. Strengthening the data that we can be able to collect as we are using the devices, looking at the effectiveness and the efficacy data, so that we can be able to input the data back to patient care and improve the quality of the patient care. Thank you.
Thank you, Anthony. Very, very important points. I'm going to move us along now because I see we're running out of time. I see a couple of questions in the Q&A that we're going to come back to. Appreciate that. They're important and useful. But I do want to turn now to Mariana Widmer from the World Health Organization. She works in the maternal perinatal health research team in the Department of Sexual and Reproductive Health and Research at WHO. She's a biochemist by training. She's focused on the health of women during their pregnancies. And over the most recent years, she's been focused on reducing the number of women suffering from postpartum hemorrhage. She's currently conducting research to identify effective interventions and to prevent and treat postpartum hemorrhage, mainly in LMICs. So, Mariana, welcome. Thank you for joining us. Couple of questions for you. With so many tools on the horizon and all the challenges associated with this type of research, what are the characteristics of research that will influence WHO guideline development and modifications?
Okay, thank you. Thank you, Dilys. Thanks for the question. And okay, so to make a recommendation, as you all know, WHO always requires rigorous evidence of benefit over harms. And sometimes this represents a problem mainly because of the enthusiasm that health workers have when applying anything that seems to have a potential. So looking what is happening with uterine devices for PPH, there are lots of published case series overwhelming the research space, which help, of course, the quick introduction into practice of certain devices, but at the same time, they remove these clinical equipoise that we need at the research sites. In addition, as in your presentation you showed, there are several devices that we are talking about that they are industry patented innovations. And when WHO makes a recommendation, we need to make sure that we are not promoting a product owned by a private company, but rather recommending a device that is safe, effective, inaccessible in low and middle income countries. So, to answer your question, to ensure that the research addresses rigor required by WHO, first of all, we need to agree on the research question, of the main research question. And actually, the current WHO UBT guideline that we published a couple of years ago, I think it could help identifying those questions. Why? In this guideline, there is a section on evidence gaps that could serve as the basis for formulating the research questions. Regarding the type of research, of course, randomized controlled trials are the preferred source of evidence for measuring the effects of interventions, but there are other types of research also possible, and we have mechanisms to evaluate those. So when making a recommendation, WHO will first look for evidence of benefits over non-use of this intervention, and then we'll look at the comparison between the interventions. Now, regarding the design of the research study, when multiple options exist for any given condition, WHO would look for the option that is not just the most effective, but also cheapest, most feasible and acceptable by users and recipients, that is cost-effective and scalable. So, for example, we are about to start a randomized controlled trial that is a multi-arm, multi-stage design for comparing different uterine devices. And of course, we are doing it, so we really think that this is a good design to go with, because it gives you the possibility to compare different types of devices and pick the best safe and efficacious device and compare it again with the standard practice in the hospitals. So overall, many times we are saying, oh, we have limited funding, so let's use what we have and make a recommendation based on what we have because of mainly the limited funding. Unfortunately, that's not an excuse for using poor quality evidence to make WHO recommendations. WHO recommendations are based on good quality evidence, and so far, as you know, there is insufficient evidence to determine which device is best. So there are lots of things that we need to look at, but I think working all together and knowing exactly what's in the ground, the evidence, we can identify the best question to go for in the research.
Great. Thank you, Mariana. I'm cognizant of time, and I want to address a couple of the questions that came up in the Q&A, so I'll come back to you with another one if we have time. But I do want to answer the question about how confident we are in the results of both of the surveys that we conducted. And I think that's an excellent question. We didn't probably qualify that enough, that this is a very limited sample. The people that responded. There were not a ton of them. We sent it out to a lot of people. And we recognize also that it was people that generally have some experience with these devices that are responding. So, you know, that is a very important kind of limitation that we need to all be aware of in terms of interpreting these results as we are doing. I'm going to go back also to this quick question to Alice. And if you can put your camera back on, Alice, whether you have any advice for how to manage the constant transfer of providers and the need for training on devices. As you know, you train, so you train them and then they leave. Do you have any device or comment about that, Alice, if you're still there with us?
Yeah, about...
Can you put your camera on? Oh, great, thank you.
About training the staffs and taking them from the areas of work is not very common nowadays. Before it used to be there, but now you find that people are specializing on one line of nursing. So you are going to get midwives in the maternity unit. And again, those who are in rural areas, especially the rural levels of the care, whereby the most burden lies in because they don't even have a doctor to assist them. If they are trained up with a device which is easy to use and which is acceptable, I think it is going to do a lot of good, and because those are the people who really panic because they don't have anyone to help them, And again, once they get that anxiety, they even don't know what to do. By the time the patient reaches now the level where the patient can be assisted, it's already too late.
Thank you, Alice.
Thank you.
I appreciate that. Okay, cognizant of time, I'm going to leave this last question to Mariana to kind of close us out here about any advice you have about coordinating this type of research. So, you know, you're in the position of conducting research, evaluating research of others, and are a key stakeholder and player in this sort of panorama. So what advice do you have about how to coordinate these efforts so that the community knows who is doing what, where, and why?
Well, it's our mandate to coordinate these efforts, if you want, as HRP. So I belong to a special program within WHO that's called HRP, which the main mandate is to coordinate this global research agenda, in our case, in the case of maternal health. And for that, we are closely monitoring what is happening in this space. And given the rapidity of emerging options, we are planning a global convening to review research agenda and to provide guidance for all the stakeholders before the end of this year or early next year. And this, I think, would be a good space where to discuss about uterine devices, suction and balloon tamponades. So we have already gone through a similar exercise with, for example, the labor care guide. And I think this summit that we call that we would like to do at the end of the year, it's a good possibility.
Great, thank you so much. And it's great to hear that you are all at WHO so committed to moving this forward and actually hoping to bring in more players, more ideas, more diversity there. All right, I'm just going to end this, cognizant of time. I want to thank everybody for being here. Thanks again to the Gates Foundation for supporting this work. It is going to be available on our website, so please do visit there. And we will also be publishing a white paper or publication with a synthesis of this work. Thank you, everybody, for joining us, and please contact us with any questions or further information that you would like. Thank you.